Yeah. So shall I start? Okay. So good evening and a warm welcome to one and all for the Thyroid Clinics. Yeah. So good evening and a warm welcome to one and all for the Thyroid Clinics session. We are very happy and excited to have all of you with us today for an informative session on thyroid health. But before we start today's session, there will be a brief video on the Indian Thyroid Society, which represents the society's mission, its current efforts, and the influence we have in achieving and aiming for advancing the thyroid health. I request the tech team to please share the video.
तस्य भास सर्वमिदं विभाति.
Thank you. The Thyroid Clinics is currently being led by our distinguished faculty, Dr. Pramila Kalra Madam, who is the President-elect, and Dr. Roma Pradhan Madam, who is the Executive Committee member. So we have also with us Dr. Narendra Kotwal sir, who is the President of Indian Thyroid Society, Dr. Arun Menon sir, the Secretary, and Dr. Mini ma'am, the Treasurer, whose contributions are definitely considered to be immense in conducting the program. We are also joined by the Thyroid Clinics team, that is Dr. Chitra Madam and Dr. Vijay Reddy sir. Before we start, I request our President of the Indian Thyroid Society, Dr. Narendra Kotwal sir, to give the opening remarks.
Thank you, Dr. Gyanvi. Good evening, everyone, and welcome to Thyroid Clinic web series held under the aegis of Indian Thyroid Society. In this particular sessions, prominent endocrinologists across the country dwell upon clinical cases and contemporary thyroid topics, which help to enhance our understanding and clear various doubts which we have in our day-to-day practice. I would like to express my gratitude to all the faculty members who are participating, who are taking a time from their busy schedule to be in this webinar, and to all the delegates who would be actively participating. As far as the Indian Thyroid Society is concerned, we are committed to enhance this particular program so that it becomes more interactive, more informative. Thank you. Jai Hind.
Thank you, sir. Thank you for those insightful words. I now request our President-elect, Dr. Pramila Kalra Madam, also to say a few words.
Thanks, Dr. Gyanvi, and I welcome everybody. And thanks, Dr. Narendra Kotwal sir, for the introduction and for kickstarting today's Thyroid Clinics. And this is another edition of Thyroid Clinics, and we know that the clinics are meant to be participated by the endocrinologists, endocrine surgeons, as well as nuclear medicine specialists. So we totally discuss only about thyroid, and this is the only clinics in India which are discussing only about thyroid and not any other topic. So I think we'll have an interesting discussion lined up today, with a lot of eminent faculties being part of today's meeting as well. And an interesting quiz for the students also is lined up. So I hand it over back to Dr. Gyanvi to carry forward the proceedings.
Thank you, Madam. Thank you for those opening remarks. So I now request the tech team to display the QR code, through which those who are interested to submit their journal to our flagship journal, that is the Thyroid Clinics Research and Practice, they can do so. So yeah. So this is the QR code. So those who are interested to submit their journal can do so by scanning this QR code. And those who are interested to become reviewers for the Thyroid Research and Practice Journal can do so by scanning the QR code. This will help you sign up as a reviewer as well. So coming over to today's program's overview, our session will include a case presentation. So this will be presented by Dr. Ankush Upneja, who is a senior resident in the Department of Endocrinology, IMS and SUM Hospital, Bhubaneswar. The case will be moderated by Dr. Jayashree Swain Madam and Dr. Sachin Mittal sir. Following this, we have a very interesting talk by Dr. Pooja Ramakant Madam, who will deliver a talk on Graves' disease with papillary microcarcinoma and malignant ophthalmopathy, and followed by an engaging quiz by Dr. Andresa Jose at about 8:50 p.m. So moving forward, I'd like to invite Dr. Vijay sir to introduce the moderators for the case discussion. Over to Dr. Vijay sir.
Good evening to all. Thanks, Dr. Gyanvi, for setting the stage for today's ITS clinics. So the first case presentation will be done by Dr. Ankush Upneja, who is Senior Resident, Department of Endocrinology, IMS and SUM Hospitals, Bhubaneswar. And to moderate this session, we have Dr. Jayashree Swain, Madam, who is Professor, Department of Endocrinology and Metabolism, IMS and SUM Hospital, Bhubaneswar. She is also Secretary of Odisha Endocrine Society and IMA AMS Odisha. She's got multiple achievements and many publications and excellent teachers awards. Welcome, Madam. Other moderator for today's discussion will be Dr. Sachin Mittal, Consultant Endocrinologist, Fortis Hospital, Mohali and Sweet Diabetes Foundation, Chandigarh. And he has got multiple awards. He was also awarded the Best Resident Award during DM Endocrinology at TN Medical College and BYL Nair Hospital, Mumbai. Welcome, Dr. Sachin Mittal. So we know that thyroid eye disease is an important extra thyroidal manifestation of thyroid disease. And usually it's often mild to moderate, but sometimes we get severe disease. So we have important discussion on thyroid orbitopathy presenting with dysthyroid optic neuropathy. Over to Dr. Ankush.
Good evening, respected faculty members. Am I audible now?
Yeah, you are audible.
So first of all, I would like to thank ITS for giving me an opportunity to present my case. I would like to share my screen now. Is my screen visible now?
It's visible, but the PPT is not visible yet.
Okay. Is it visible now? No?
Yeah, it's clearly visible. You can put it on the PPT mode.
Yes, yes, ma'am.
Make it full screen. Yeah.
So good evening all. Today I am going to present my case on Graves' orbitopathy presenting with this thyroid optic neuropathy. So I am presenting a case of my patient Nabagan Mohanty, 62-year-old male, who is a resident of Cuttack and is a retired army personnel by occupation. So he presented to us with chief complaint of redness of bilateral eyes since 3 months, protrusion of bilateral eyes since 1 month, and blurring of vision since 20 days. So patient, as already described, is 62-year-old male, and he presented with following chief complaints. It started with redness of bilateral eyes. It was associated with excessive watering and foreign body sensation in both the eyes. Over the next 3 to 4 weeks, patient noted progressive protrusion of the eyelid, that is protrusion of both the eyes, but it was asymmetrical. That is, eyelid right eye protrusion was more than left. 15 to 20 days after this, the patient experienced blurred vision, and it was also associated with moderate pain at rest and also at uh, intermittently at eye movement. There was no history of diplopia, there was no history of acute loss of vision, there was no history of any complaint of impairment of color vision, there was no history of ptosis. So patient was tested for hyperthyroidism 20 days after the ocular symptoms. Patient had history of mild tremors, but there was no history of any palpitation, increased sweating, weight loss, or heat intolerance. There were no other thyrotoxic symptoms like increased stool frequency, neck swelling, dysphagia, hyperpigmentation. There was no history of any swelling or redness over the legs. There was no history of any postural dizziness. There was no history of any fractures, gynecomastia, or erectile dysfunction. Combined with this, there was no history of any fever, jaundice, dyspnea, or pedal edema. When ocular symptoms appeared for the first time, he was prescribed from local clinic some eye drops. After that, he did not have any relief, and he went to an ophthalmology clinic where he was advised for MRI orbit and thyroid function test. And patient was thereby referred to endocrinology for further treatment. There is no past history of any diabetes, hypertension, or any thyroid related illness. There is no history of any chronic disease. Patient is non-smoker, non-alcoholic, bladder habits were normal, and there is no such complaint in the family also. So coming to examination, the patient had mild tachycardia and pulse was regular, normal in volume, and there was no pulse deficit. BP was 114 by 75, 74 in right arm supine position. Patient had a BMI of 25.5 and there was no pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema. Patient had fine tremors, otherwise no other symptoms in the hands were not warm, there was no onycholysis, there was no thickening or redness of skin over the shin, there was no vitiligo or hyperpigmentation. On thyroid examination, thyroid was normally palpable and no lymph nodes were palpable. So coming to eye examination, in eye examination, the patient had conjunctival swelling in bilateral eye. Patient has conjunctival redness in bilateral eye. Patient had spontaneous pain in the right eye, and the patient also had exophthalmos of 23 millimeter in the right eye and 20 millimeter in the left eye, and visual acuity was 6 by 9. So the CAS score, that is clinical activity score, in right eye was 4 by 7 and left eye was 3 by 7. So patient had clinically active disease. So further, patient also had lid retraction, 3 millimeter in the lower lid of the right eye. Lid lag was present. There was no lag of thalmus. Pupil were bilaterally symmetrical and reactive. There was no RAPD. But the main thing was that on evaluation, we found that patient had defective color vision. When we used Eschara chart color plates, we found that in the right eye, the color vision was 8 by 25. In left eye, it was 10 by 25. Further, in ophthalmology, contrast examination was also done, and it was found that there was a contrast deficit. In right eye, it was 13%. In left eye, it was 25%. And moreover, there was restriction of right eye movement on the temporal side. So this was the contrast examination which we did. So there are the marks as we can see 16%, 13%, 25, 50 and 100. So the normal patient without any eye disease can easily see 6% contrast. But as the in patient of Down, this contrast sensitivity decreases. So our patient was able to catch up that 30% and 25% line. So there was contrast deficit, which was again a clue for us. So we made a clinical diagnosis of Graves' disease with thyroid associated ophthalmopathy with clinically active disease with CAS of 4 by 7 in right eye and 3 by 7 in left eye with Dawn with severe disease without any features of dermopathy and acropathy. So again, we went for investigations. In investigations, all the investigations were grossly normal, and thyroid profile TSH was less than 0.005, T4 was 20.3 microgram per deciliter, and T3 was 354 nanogram per deciliter, showing a thyrotoxic feature. And TRAb levels were slightly raised, like they were 12. So we went for MRI orbit, and then MRI orbit we can see that there were muscle enlargement in both the eyes. Muscle belly was involved, and there was sparing of the tendons. There was proptosis also, and there was slight apical crowding was also noted. So we made the diagnosis of Down. We started the patient on IV methylpred at a dose of 1 gram daily for 3 days. And after that, we asked patient to follow the steroid maintenance regime, that is 500 mg weekly for 6 weeks, followed by 250 mg weekly for 6 weeks. Along with that, we gave mycophenolate mofetil and antithyroid treatment also. So, to our expectations, there was a good response to the treatment, and there was relief in symptoms of the patient. That is, there was decrease in the conjunctival congestion, there was decrease in periorbital edema, and the parameters which were earlier deranged, like uh, CAS score, which was 4 by 7 and 3 by 7, it reduced to 2 by 7 and 1 by 7. Color vision also improved in both the eyes. And contrast deficit, which was there, it was not completely recovered, but there was a significant improvement in contrast sensitivity also. So we present this case because of 2 to 3 things. First is that patient had asymmetrical eye involvement that occurs in around about 9 to 30% of the cases, and unilateral disease, it can occur in 10% of the cases. Second, the patient had dysthyroid optic neuropathy, which is characterized by visual loss, color vision deficits, contrast sensitivity, optic nerve compression, and it occurs in 3 to 8% of the Graves' orbitopathy cases. We wanted to present this case because the patient did not have any much, what we say, much complicated symptoms. He only had a slight symptom of color vision defect, and there was contrast sensitivity reduction. So these features has to be seen in every Graves or orbitopathy patients, as these features if picked up early, and if the treatment, if we give 1 gram methylpred for 3 days, they can give a significant improvement in the patient, as these patients require urgent immunosuppressive therapy as compared to Graves' orbitopathy. So a slight introduction about Dawn. So it is a severe complication occurring in about 3 to 7% of the patient, and it can cause permanent vision loss if it is untreated. So prevalence of Graves' ophthalmopathy is 25 to 50% in Graves' disease patient. It is female predominant, and males have the serious disease. We know that. But the prevalence of dysthyroid optic neuropathy is 3 to 7%. Thyroid eye disease, it follows a biphasic course. That is, first there is an active inflammatory phase, then there is followed by inactive fibrotic phase. Risk factors of dysthyroid optic neuropathy, there can be genetic environmental factors. Smoking is risk factors. Diabetes mellitus, followed by radioiodine therapy. Older people have greater risk of Down, and male sex are at higher risk. And with this, TRAB levels also. High TRAB levels have a potent risk for Graves' orbitopathy and Down. So pathophysiology is similar to Graves' orbitopathy, as we all know that there are IGF antibodies, they IGF receptors. These IGF receptors, they will activate the PI3. These IGF-1 receptors, they will activate the PI3 AKT pathway. This PI3 AKT pathway, it will lead to increased hyaluronic acid formation and increased fibrosis. Similarly, the TSH receptor antibodies, these TSH receptor antibodies, they will activate the CAMP pathway, and they will also activate the mTOR pathway, and they will lead to conversion of orbital fibroblasts to adipokines. So as the adipokines will form, there will be expansion of the orbital space along with fibrosis, and due to expansion, there will be or optic nerve stretching and optic nerve compression. So the basic pathology of Dawn is the superior orbital fissure compression along with these features. So in clinical presentation, as we have already discussed, visual acuity will be low, there will be color vision defect, there can be RAPD present, contrast sensitivity will be low, and there can be visual field defects also. So what is the difference between Graves orbitopathy and Dawn? So Graves orbitopathy has a gradual course, but in Dawn there is a sudden course and patient can directly land up in with severe vision decline. And there is again impaired color vision will be there, contrast sensitivity will be low, RAPD can be present, and exophthalmos, which is mostly symmetrical in Graves orbitopathy patients, they are mostly asymmetrical in Down patients. And there is high risk of vision loss. Therefore, Down patients have to be managed uh, as ASAP. So in imaging, as already discussed, there will be apical crowding, muscle enlargement, and MRI T2 weighted stir imaging is the imaging of choice for these patients to differentiate between edema versus fibrosis. So, what is the medical therapy management? In management, we first try with glucocorticoids, IV methylpred with dose 0.5 to 1 gram daily for 3 consecutive days, and cumulative dose should not exceed 8 grams. So, with steroid therapy, the visual acuity improvement is in about 20 to 60% of the patients. And if visual acuity is not improved, what we can do is we can either repeat the steroid dose or we can go for surgery. So if there is poor response, the orbital decompression has to be done in within 1 to 2 weeks. So additional IV pulses can be given or we can go for surgery. Mycophenolate mofetil has been tried and biologicals also have been tried like taprotumab, which is an FDA approved drug for Graves orbitopathy, has shown to improve proptosis and also decrease the CAS score. Similarly, tocilizumab is also effective in glucocorticoid resistant cases. Rituximab is not recommended for Down due to its property of causing flu-like symptoms with cytokine release and further worsening the optic neuropathy. So when we talk about surgical therapy, so in surgical therapy, our motive is to reduce the pressure, relieve orbital apex crowding, and in surgical therapy, we follow these three procedures. First is transnasal endoscopic decompression, which is minimally invasive, and it has caused visual acuity improvement in around about 60 to 80% of the cases. And there can be balanced decompression in which we uh, compromise the medial and lateral wall, and there will be a greater proptosis reduction, but there will be a diplopia risk, though less. But in three-wall decompression surgery, there is maximal space gain, but there is high risk of diplopia. So surgery has to be done within 1 to 2 weeks if there is no response to IV therapy. So these are the studies in which they have seen, we compared steroids with surgery. What is better? So in first study, they have seen that there was a much greater improvement if orbital decompression is done first, followed by steroids. There was 83% remission rate as compared to IV steroid, which was only 44%. And in all other studies, they have seen that the effectiveness of steroids along with decompression surgery has a greater remission rate as compared to steroids alone. So in all these studies, they have come to a conclusion that with steroids, surgery has to be done for better remission rate. So in second line, as we already discussed, that following biologicals have been tried, and among these biologicals, teprotumab has shown the maximum remission rates in Down patients. So when we talk about Indian data, so in Indian studies which has been done on Dawn, we have found out that like in this study, there were 214 patients and out of them 26 were Dawn patients. So in Indian settings, we have seen that The prevalence of DON, which we discussed, is only 3 to 7%. In both the studies, is more than 10%. So in Indian settings, DON is not that uncommon. And respond and about 65%, or we can say 70% of the patient have responded well to IV steroids only. And though surgical response rate is more, but there is a good response rate with IV steroid also. So when we come to radiotherapy, radiotherapy alone is not recommended, but radiotherapy along with steroids can be used as a therapy for DON in patients who are not responding to IV steroids, or in patients uh, who have recently been discovered with Graves' orbitopathy and fibrosis had not yet occurred. And the dose of radiotherapy is 20 gyri in 10 fractions over 2 weeks. So it has to be used with glucocorticoids. Mechanism is same, that it reduces the orbital fibroblast. It is best for the patient who are infant for the surgery or there is mild DON and recent Graves' orbitopathy without fibrosis setup is there. So in radiotherapy, they have again seen that there is resolution, but this is again when the patient is either steroid or surgery resistant, radiotherapy has to be done. So in conclusion, I want to conclude that the prevalence of DON is around 3 to 7%, but in Indian settings, it is around 12%. So the subtle signs of dysthyroid optic neuropathy should not be missed. And every patient who comes to OPD, we have to check for color vision and contrast deficit also. So there are subtle signs like decreased visual acuity, contrast loss, RAPD. Steroids have to be given first. If no response, then we have to go for urgent orbital decompression. But in our Indian OPD settings, if most of the patients are not ready for surgery, so we can repeat the IV methylpred dose and we can give up to 7.5 to 8 grams maximum dose. Adjuncts like mycophenolate, teprotumumab can be tried, although rituximab is not. So a multidisciplinary approach is needed, like endocrine ophthalmology, to deal with the disease. Thank you.
Thank you, Dr. Ankush, for this nice presentation. Dr. Janavi, is there any questions in the chat box?
I'm in the chat box. I'm not able to see any questions. I request the
Yeah.
tech team, if there is any questions, can you please display, tech team?
I invite Dr. Mittal for the discussion. I think, say, Dr. Ankush, you have missed this visual field effect. That is the one of the most important thing. And if somebody is coming with Graves' orbitopathy, exophthalmos is there. If complaining of visual acuity, or you should check the visual acuity, that is very simple test in outdoor basis. You can go for that.
Yes.
Decrease of visual acuity, along with that impaired color visions and visual field defect. This is clinical manifestation. And another important things you have elaborate more, but that is a stretching of the optic nerve.
Yes,
In MRI, you can go for that. And in clinical setup, you can go for this relative afferent pupillary defect. You can go for that. These three, when somebody is coming with this orbitopathy, we should look for that. As the reversals after treatment, the visual acuity, the gaining of the visual acuity is not 100%, is approximately 50-60%. And from if I search for the literature, and from your presentations, I think one thing is there, done is more in this Indian setup. And in Indian setup, it is very much responding to this steroid. And if you look to this 2021 guidelines, UGOGO guidelines, it is supported by this European Society and American Society. Along with the steroid, you can prescribe the mycophenolate mephiles. Along with that, it is the first line of the treatment. What is your opinion regarding that, Dr. Mittal, sir?
Yeah. First of all, nice presentation, Dr. Ankush. And
Thank
I agree with madam. And the clinical point which madam highlighted is very, very important, that if any patient presenting to us, especially with vision loss, color desaturation, and you also highlighted the pupillary defect, right? After on that will be on examination, because having a good index of suspicion is very high, because you have on one side you have thyroid eye disease, and then you have thyroid eye disease with Dawn, which is a completely different entity in terms of clinical implications and the prognostic implications. And I agree with madam that the steroids response in our setup is good. However, after your presentation, I was intrigued to know that in the Indian setups, which they saw about 200 odd patients and about 225 odd patients with Dawn, did they have any patients where they did the surgery alongside steroids also, or they followed the protocol only where they did only the steroids followed by non-responders going to surgery?
Sir, it was steroids, and if they were not responding, then they went for surgery. It was not the steroids which were followed by surgery.
But
I
based on
think
the
most,
literature,
yeah, sir, you complete.
no, please, yes, please, please go ahead, ma'am.
So if you look to the literature, most of these study with steroid along with that decompression therapy, the result is good. But the result is not 100%. Visual acuity will not it coming to this normal in 100% of the cases. It's only 60% cases with steroid and that decompression surgery. And decompression surgery is as early as possible within 1 or 2 weeks of the if the patient is not responding to this steroid.
Right, ma'am, right. I think just benefit of audience, Dr. Ankush, you can highlight the differences in terms of steroid protocol that we used in patients with Dawn versus only thyroid eye disease without dysthyroid optic neuropathy, like without Dawn. So what is the difference in terms of steroid protocols that we usually use? If you can highlight that for the benefit of the audience, that will be beneficial.
According to guidelines, sir, for Graves' orbitopathy, we use a dose like 500 mg once weekly for 6 weeks, followed by 250 mg once weekly for another 6 weeks, followed by a mycophenolate mofetil, that is 0.72 gram per day. And in Dawn, we use slightly higher dose, that is recommended dose is 1 gram per day for 3 days. So to maximum of 8 grams we can give, and we can repeat the same dose if patient is not improving, sir.
Yeah, very, yes.
Yeah, here I'd like to comment. In mycophenolate method, you can give up to 28 weeks, and in some study they have given 70 weeks.
Okay.
I have gone to the literature, 70 weeks they have given.
Okay, thank you. And also very important to highlight for the benefit of any postgraduates which are saying that what kind of a simple monitoring we can do for any patient receiving pulse steroids, which is not to be missed. Like, say, any specific monitoring you like to do, Dr. Ankush?
So monitoring, like we have to check for patient plasma glucose levels have to be checked. Secondly, the risk of the grave adverse effect like hepatitis and liver injury, though are very less, but they have to be seen in these kind of patients.
No, recommendation is there. You may go for the liver enzyme ALT S3. Recommendation is there. And along with that, blood pressure measurement in each and every visits.
Yeah, steroids, when you're giving pulse steroids, some patients, they can develop hypertension. Some patients may have some degree of hypertension in the background. And when you're giving a high dose pulse steroids like 1 gram IV daily, it can lead to a exacerbation of hypertension. So like madam said that, it's recommended that sugar monitoring, blood pressure monitoring. And the concept about the cumulative dose also comes because there is a risk of hepatotoxicity, which, you don't want to exceed a cumulative dose. That's why you mentioned about the 8 gram cumulative dose. And conventionally, we talk in guidelines about the 4.5 gram cumulative dose when we're giving 500 milligram. Yes. So, yes, ma'am. Over to you for further questions. Any further questions? If any further comments, ma'am. Dr. Pramila also is here, and Dr. Vijay also is here. Any comments?
Remark, any comments? I'll invite Dr. Pramila and Dr. Vijay sir also. And Dr. Roma is here. Yeah. Dr. Pramila, please.
Yeah, I think we had good discussion because we are just, we can check that if we have any online questions, because that we can take. Ganvit, is there any online question which is there?
No, ma'am. As of now, no. Yes.
Okay. So I think what is the role of like one more question which we can discuss for the benefit of the audience, that when do you decide in such cases to go for radioiodine? Because once the orbitopathy is severe and moderate, obviously we don't. But in mild cases, what is the protocol you follow if you have to go for radioiodine ablation? Because audience would like to know, because there are a lot of doubts amongst people that if it's a mild orbitopathy, then should we wait or should we go ahead with radioiodine? And do you monitor the TRAB antibodies regularly in these patients? Or what is the role of TRAB in this? So these two questions I think we can take for the benefit of the audience.
Ma'am, TRAB levels as
Yeah, you can go. You can go.
Yeah, you can
Ankush,
tell.
you can
Yeah. Yeah.
Ma'am, TRAB levels, as we know, are not recommended for diagnosis, but TRAB levels we did only
Yeah.
because we wanted to monitor the response and see if
Right.
patient has gone into remission or not. Secondly, radioiodine, ma'am, as such, as a single therapy, it is not recommended for DON treatment, as after
No, we are not telling the radioiodine as a treatment for DON. What we are discussing is treatment for Graves with radioiodine in mild orbitopathy. That is what we are discussing. We are not discussing it as a treatment for the orbitopathy, but we are discussing how to give radioiodine ablation, steroids and all that, because we do mild cases, it can be ablate. And if we do, then what is the steroid regimen you follow?
ma'am, steroid regimen in this.
Now here I like to break here in one point of TRAB level high, at the beginning is very much necessary if you are
Right.
suspecting it is a case of this done, because high TRAB levels that may be resistant to these steroids and immediately you go for this surgery. That is one point is very much clear in this guideline. High TRAB level at this beginning, patient may land in this resistance to these steroids and you may go for this surgery. Or other alternative, the first line of the therapy is the steroids along with the decompression and this mycophenolate method, and the second line of the therapy is always the biologic. So once TRAB level is very high, we should think about the alternative therapy. That is the point. And regarding the radioiodine, Dr. Mittals, I think so you can clarify that thing.
Yeah, Dr. Mittal, you would like to comment on this radioiodine? And
So
radioiodine,
the most important thing to remember is that if you have a moderate to severe disease, right, there is a possible risk of worsening. With mild disease, you can probably consider it under the cover of steroids.
Yes.
Honestly speaking, I don't do it. Because even if you do it in 10 patients and it worsens in one
patient may worsen,
and that one patient is equal to 100 actually.
Correct. So practically what we opine is that definitely we can do it in mild cases under cover of steroids, but if you have a suspicion, it's a good idea to see that the disease is under control and not progressing, because some of these mild cases may become moderate to severe and then it can be a problem. So I think it's a good idea to wait and give antithyroid drugs unless it's an absolute contraindication for ATD and you have no other option but to go for ablation is a different scenario. But otherwise, we normally give ATD, wait, let the orbitopathy come under control, and then go ahead. That's what most of us agree with, because mild also is a little bit of risk case, which can worsen, as you rightly said, that if some cases worsen, it may be a little bit of an issue. But if we have to do it, we have to give steroids, cover oral also we can give as per the guidelines, and we do it.
At this point of time, I think.
Yes,
sorry.
One point here. Yes. In case of the done, when you are giving the orbital radiotherapy, that is also aggravation in some cases. It is reported, and along with the steroid, you can give early worsening of the done is seen with the orbital radiotherapy.
Right. Yeah, Dr. Sachin, you wanted to say something?
No, I think probably we're getting late. We can go on with the session. There's a next presentation also.
Yes, Dr.
Yes.
Pooja is waiting.
Yes. Thank you very much, Dr. Ankush. You did very well for the presentation. Thank you.
Thank you, Ankush.
Thank you.
Thanks, Dr. Jayashree and Dr. Sachin. Very nice discussion.
Thank you, ma'am.
Thank you, Dr. Ankush, for a very interesting case presentation, and special thanks to Jayashree ma'am and Sachin sir for your valuable insights and moderation as well. So next, moving on, I'm pleased to welcome Dr. Roma ma'am to introduce our guest speaker for the next session, that is Dr. Pooja madam. So over to Roma madam to introduce Dr. Pooja.
A very good evening to all. We all know that Graves' disease is associated with the thyroid cancer, especially when there is a nodule in it. So the chances are around 17 to 20% maybe. So after this interesting case presentation on Graves' eye disease, we have this talk by Dr. Pooja Ramakant, ma'am, who is the professor in endocrine and breast surgery department at KGMC Lucknow. And she has multiple achievements to her. Without wasting time, I would like to invite Pooja ma'am to continue that.
Thank you, ITS, and thank you, Roma, for inviting me. I'm just getting my PPT. Can you see my screen?
Not yet, ma'am.
Mhm. Can you see now? Can you see my screen?
Yes, ma'am.
Yes, ma'am, we can see. But it's from the phone that you are presenting.
Yeah, it's from the phone. Now is it okay?
Yeah.
Yes, ma'am.
Yeah.
So thank you. And Dr. Ankush has nicely made a background for discussion on Graves' disease with ophthalmopathy. So I shall be discussing on two aspects. One is the papillary microcarcinomas, and other is like he talked about Dawn. I will be talking about severe vision sight threatening ophthalmopathy or malignant ophthalmopathy. So comparing his patient, I think every patient is different and we learn different aspects. So that was an elderly male with a short duration of history, what he presented. Our patient is 48 years lady who had history of hyperthyroidism for 7 years and she was on neomercazole on and off medications. However, she had eye pain and all symptoms of eye problems for 4 to 5 years, which worsened in the last 1 year. And she had bulging of bilateral eyelids, but diminished vision happened 4 months back. So she consulted endocrinology department in March 25, and then she was started on IV dose of steroids, as we have seen in the first case also. From there, she was referred to ophthalmology, where they did a suture tarsorrhaphy, which gave dehiscence after 1 week. So then she was referred to us from the ophthalmology. So she didn't had any compressive symptoms. You can see her steroid dose, the way she was steroid therapy was given from March till June when she was referred to us. So she was known hypertensive and diabetic, otherwise no other comorbidities. Examination wise, she just had a diffuse enlarged nodular goiter, nodular because she had been on 7 years with neomercazole. That makes it firm and nodular. Otherwise, no lymphadenopathy, so no clinical signs suspicious for malignancy. Coming to the eye disease, she had severe sight-threatening Graves' ophthalmopathy, grade 3 proptosis bilateral. Right side, you can see corneal ulceration is there, redness is there, lid lag, lid retraction, all signs were present. And right side, the visual acuity was just perception of light. And her clinical activity score was 5 out of 7. And UGOGO classification, it was severe sight-threatening Graves' ophthalmopathy. So these are the various pictures of hers. And she had, compared to right and left, she had both sides eye disease. Right was more dominant. And like you see other things in spite, apart from tonometry and other lid lag, other ocular movements, her tear breakup time was less than 10 seconds. So it showed that dry eyes, and Schimmer's test also 15 and 10 millimeters. So with this diagnosis, she was evaluated as she was on neomercazole when she came to us in July. She was euthyroid on medications. TRAP was elevated to 84. Res BMD showed mild osteopenia only. And we did the ultrasound, which showed both side nodules, solid cystic, TIREDS 2. And she didn't have any lymphadenopathy. Her MRI orbit was done, where you can see both sides, the rectus muscle, the medial rectus and the inferior rectus were hypertrophied, the red arrow and the blue arrow. And the fat was normal, and she had proptosis both sides. The distance from the interzygotic line was around 29 millimeters, 27 millimeters, and she had grade 3 proptosis. So fat was not enlarged, only just the muscles were hypertrophied with proptosis. So with this scenario, we planned her for total thyroidectomy. The specimen of the weight of the specimen was just 40 grams. Normal thyroid weighs around 30 grams, so it was mildly enlarged only. Surgery, the intraoperative period and immediate postoperative period both were smooth, uneventful. She didn't had any hypocalcemia and was discharged in a normal condition. These were her calcium values. The calciums were normal. PTH also was 43. Pre-op and post-op day 1 was 28 and 18. So in the normal range only. Her histopathology came out to be microcarcinoma thyroid, papillary oncocytic variant. So now we don't say papillary microcarcinoma, there's a separate variant. We just classify into PTCs only. And this oncocytic variant is slightly aggressive, though it is debatable. So she was started on levothyroxine and ophthalmology review was again done. And from their side, they have planned for right eye mulirectomy with the levator palpebrae superiorlis revision with lower lid detractor release and orbital decompression also. So she has been on steroids for last few months and 2 months after surgery, we called her last week to see her assessment and her both eyes, there's improvement. And now her clinical activity score is 3 and she has improved symptomatically. You can see her clinical picture also. She can close her eyes also, though she is on steroid therapy still now. Though, however, she is planned for eye surgery in the next few weeks. So with this scenario, I shall be focusing first, how does cancer happens in Graves' disease? Both are associated with inflammation. And this chronic inflammatory environment causes the development and growth of cancer cells. And Virchow in 1863 itself showed leukocytes in cancer tissues and suggested the association of carcinogenesis and inflammation. So you see that tumor microenvironment and inflammatory cells are connected through fibroblasts, endothelial cells, through cytokines, chemokines, and adipocytokines. So Hashimoto's thyroiditis and Graves' disease have expression of DNA damage, which favors development of PTC in both these scenarios. The incidence of PTC, however, this ranges 2 to 17%. ATA says 2% in Graves' disease. However, in other studies, it is much higher than what ATA says, up to 17%. If there is thyroid nodules, then there's a wide, broad range from 2% to 45%. So another study of 243 Graves' disease, 20% had PTCs, 14% had microcarcinomas, mostly were younger females, and it was incidental in 48%. What was common was hyperthyroidism was difficult to treat, and 2% only had recurrence. So there's a controversy of saying whether Graves' disease impacts the prognosis of PTC or not, because both sides' data are available. However, PTC may not be well recognized in Graves' disease, so pre-op assessment, we have to look for cancer development. Other interesting thing is that patients who have Graves' disease with coexisting thyroid nodules, they are 5 times more likely to have thyroid cancer than those who have just diffuse goiter, no nodules. And a fact is that failure to detect malignant thyroid focus in ultrasound or nuclear scans, though as these are very tiny foci. And both malignancy and autoimmune thyroid disease appear as hypoechoic areas, so we may miss microcarcinomas on ultrasound. I think there's something. So after the malignancy part, I'm coming to the eye disease. We all know clinical activity score. We do for finding that the disease is active or not, and we look for the severity. And like for our patient, sight-threatening ophthalmopathy was there, and this classification helps to plan the treatment. So we know the thyroid symptoms, and this classification has to be assessed in each week visit of the patient so that we assess the response to therapy. And ATA guidelines also show that we need to look for proptosis, diplopia, corneal exposure, optic nerve status, like in previous case there was drawn. And workup involves ultrasound, CT, and MRI of the orbits. And medical management we have discussed in details. The other things which can add is selenium, scleral lenses, vision aids, prisms for diplopia, along with steroids and teprotumab, which we have discussed, role of RT also. So coming to surgery, surgery addresses vision loss from optic nerve compression if there is diplopia or proptosis, which is not responding to steroids. So there are 3 types of surgery. One is orbital decompression. Second is eyelid surgery to correct the retracted eyelids, like in our patient which is being planned. And once we do these decompression and eyelid surgery, after some time, there will be reorganization in the eye and diplopia will happen. So when that happen after a few months and that stabilizes, then third stage surgery is strabismus surgery to correct those misaligned eyes and to help in diplopia vision. So 50% of the patients have Graves' ophthalmopathy. In some studies, like in Sweden, 20% had eye disease. Disease severity and activity prompt different treatments. The signs are very heterogeneous, so management is a bit complex. The first line therapy for moderate to severe active Graves' ophthalmopathy is steroids. Surgery is needed for chronic inactive fibrosed disease. But if there is John, then in acute phase itself, surgery may be done to avoid the immediate risk to vision. So active phase has all the eye problems and is usually managed conservatively, and smoking has to be stopped. That is an important point. Inactive phase, when the inflammation has resolved and disease stop, progression stops and it is fibrosed, permanent structural damages happen, and then focus shifts to restore the ocular function and appearance through surgical procedures like decompression, eyelid surgery, and extraocular muscle surgery to address a double vision, which is staged done later on. So we can easily classify as active phase when the clinical activity score is more than or equal to 4. We do the medical management, monitor the disease activity, wait for transition for the inactive phase when it is fibrotic and clinical activity score falls to less than 3. Disease is stabilized 6 to 12 months, and then surgical or rehabilitative treatment happens to help the patient. So most patients with Graves' or orbitopathy respond to conservative treatment and do not require surgery. However, only 5% patients may undergo surgery in the first year after diagnosis, and 20% may need surgery within the first decade. When dawn happens, then surgical intervention is immediate. Even in the UK study, dawn patients constitute only 2% and they initially received steroids. However, 50% patients needed surgery within 9 months. So moderate to severe orbitopathy, usually patients have lid retraction more than or equal to 2 millimeters, moderate or severe soft tissue involvement, exophthalmos more than or equal to 3 millimeters, constant or intermittent diplopias, and small minority only may require surgery when self-limiting inflammatory phase is over. So surgery in acute phase is recommended in severe exposure keratopathy, dawn patients who don't respond to steroids, and eyeball subluxation. Blepharoplasty helps in lowering the eyelids, lifts the mid-face, and reduces the brow fat pad. And upper lid retraction can be treated via levator advancement or Muller muscle, like in our patient, which she is planned for. So how are the surgical outcomes post-surgery for the eye disease? It really helps to elevate the decompression and the clinical activity score, and the nose pecs, they decline. Visual acuity significantly improves, and majority up to 88% patients get benefited. If we just do the fat decompression alone, even then we get a reduction in proptosis up to 5.9 millimeters. So fat decompression alone or along with bone wall decompression can be done simultaneously. So there's a classification where you remove only the fat, how much effect it happens. When either you can remove single wall, medial wall decompression, or single wall lateral decompression, or 2 walls, medial or inferior, then balance 2 wall, 3 wall, or 4 wall. The more walls you decompress, the more chances of diplopia happening. However, you can correct the proptosis part, and surgery may be endoscopic or it can be open approach. Then eyelid surgery helps in relieving the retraction, contraction, and the fibrosis which happens. And Muller muscle, there is sympathetic tone hyperactivity, which also triggers the upper eyelid retraction. That also can be corrected. So these are the various types of eye surgeries. So the indication for eye surgery, the planning of eye surgery, I think that when it has to be happened, those decisions have to happen. However, so with this background, I shall be summarizing that more than 1/3 patients with Graves have Graves' orbitopathy. Only 5% have moderate to severe eye disease, like in our patient, which is a rare scenario. Thyroidectomy definitely helps in improvement of Graves' orbitopathy along with steroids. And eye surgery is really needed. However, whenever it is needed, the outcomes are very good. And decision to plan these surgeries have to be taken in a combined decision in MDTs with medical endocrinologists, endocrine surgeons, nuclear physicians, and ophthalmologists. So I think all have their own role in following up these patients. So with this, I thank you for giving me this opportunity to share my case and discuss, and happy to have your comments and feedbacks. Thank you.
Thank you so much, Pooja ma'am. That was a very interesting case and a good discussion. And that is what you remember. The old teaching says that there will be no cancer when it's hyperthyroid or thyrotoxicosis. So this is to highlight that if Graves is with a nodule, definitely the malignancy rate is pretty high. So you have to be pretty careful in that. And it was a very good management. Saying the importance of multidisciplinary approach, endocrinologists, eye surgeons, then endocrine surgeons, all together taking a decision for such a difficult patient. So any more questions we have from the audience, or Dr. Vijay Bhaskar, would you like to comment on something?
No, madam, I think Dr. Pooja has presented well. I think both cases this time we had on thyroid eye disease. So sometimes it comes in seasons.
And good to see different spectrums and different way of management, and the duration and the severity of disease. So that was interesting.
Definitely.
Dr. Ganavi, shall we move forward then? The next.
Yes, ma'am. Yes, ma'am. Sure, sure. So thank you, Pooja ma'am, for this very insightful presentation on both papillary microcarcinoma and giving us insights about Graves' ophthalmopathy as well. So I request the tech team to again display the QR code for those who are interested to submit their journal to Thyroid Research and Practice, to display the QR code. Tech team.
Yes, ma'am.
So before we proceed to the quiz, again, a very short announcement. Those who are interested to submit their research to the flagship journal of Indian Thyroid Society, that is the Thyroid Research and Practice, can do so by scanning the QR code, which will be displayed. And yeah, so this is the QR code through which those who are interested to submit their journal can do so. And those who are interested to become reviewer for Thyroid Research and Practice can again do so by scanning the QR code, which will be displayed next. So this QR code will help you sign up as a reviewer. So, and now it's time for the much anticipated quiz, which most of the postgraduates keep awaiting. So, before we proceed, let's have a brief discussion on the quiz instructions. So, it is important to click on the button that is the attend quiz on the live stream screen. So, the quiz will be conducted via the Slido platform. Each question will be displayed for about 30-second time limit for responses, and the quiz has a total of about 10 questions. And our quiz master for the day is Dr. Antrisa Jose, who is a consultant endocrinologist at St. George's Medical Mission Multi-Speciality Hospital, Tiruvalla, and has multiple achievements to her credit. So Dr. Antrisa will guide us through the questions and answers, and at the end, she will also announce the winners for both the general practitioners and the DM quiz. So over to Dr. Antrisa for conducting the quiz.
Thank you, ma'am, and thank you, dear teachers, for the wonderful opportunity. Is my screen visible?
Not yet, Dr. Antrisa. You just share it. Not yet.
Okay.
You'll have to give some time for the delegates
Yeah, ma'am.
to
I'll
join.
give you the cue when to start, ma'am. Let people join. Yeah.
You can share your screen. We'll allow some time for the people to join.
We'll wait for a minute, ma'am. More people are joining.
Shyam, you can let us know when to start.
Is
Yes,
my
sir.
screen visible?
Yes, ma'am.
Screen is visible.
Yes.
Okay, thank you, sir.
They have to join on another platform, so we'll just wait for a couple of minutes.
Yeah.
Sure, sir. Sure, sir. Sure.
No, after each question, no, I'll tell you next, then you'll go to the next question.
Hello? That's okay.
So, Dr. Antrisa,
Sir?
after each question, you just wait. He will tell you next question, then only you go to the next question.
Sure, sir.
I think, yeah, we can start, ma'am.
Someone is asking where to join for the quiz.
Sir?
Dr. Ankush is asking where to join for the quiz. Just see the chat box.
1 second, 1 second. Let me give him the link then. 1 second, ma'am. Click on it, Dr. Ankush, and then register quickly. Yeah? Just waiting here. Dr. Ankush, you are able to access it?
Maybe fault at my end, sir. You can start, sir.
Okay. Ma'am, we can start then, ma'am. Yeah.
So the first question, may I start?
Yes,
Yes.
ma'am.
Sure. So, when taken after a meal, what is the percentage reduction in thyroxine absorption for 100 microgram dose? Shall I tell the options or will they read it?
Yes, you have to read the options, ma'am.
You
And
can
wait
read
for
out the
30 seconds.
options.
Yeah.
From 68% under fasting conditions to 44%, from 79% under fasted conditions to 64%, from 82% under fasted condition to 68%, or is it from 88% under fasted condition to 76%?
Okay. You can reveal the answer and go to the next question, ma'am.
I can reveal the answer.
Yeah.
Then I'll have to.
No,
No,
we'll
it's okay.
discuss the answers at the end.
Later, and then you can move on to the next
question.
Next question, yeah.
So this is regarding a 54-year-old gentleman who was started on interferon alpha for chronic hepatitis C. And he presented to the endocrinology clinic with features of thyrotoxicosis. There were no eye signs, the TSH was suppressed, and the free T4 was elevated, 2.4 nanogram per deciliter. Radioiodine uptake was negative. The consultant discontinued the interferon alpha. So what is the recommended management for the thyrotoxicosis in this case? Whether it is beta blockers alone or what is the preferred or the management? Beta blockers or IVIG, whether it is carbimazole or radioiodine ablation.
Next question, ma'am.
So today is the day which we are dealing with thyroid eye disease. So which are the eye signs that is not related to thyroid eye disease? Whether it is Ballard sign or Cogan slit twitch sign, Dalrymple sign or Gendrasik sign. Which is the eye sign that is not related to thyroid eye disease?
Next question, ma'am.
So pick the wrong state. Ironic. So levothyroxine dose is to be reduced by 25% when LT3 is to be added at 5 milligram twice daily. And leothyronin dose can be increased up to 7.5 milligram twice a day as long as the serum TSH is not suppressed. And if the TSH is suppressed by the combination treatment, lowering of the T3 dose would benefit. Or the wrong answer, whether it is if the TSH is suppressed by combination treatment, lowering the leothyronin dose would benefit. Which among this is the wrong statement?
Next question, ma'am.
So we all know about the Barrett's muscular index. What is the true statement regarding it? It is actually there is a correction in this. What is the false statement about the Barrett's muscular index? The question there is a wrong. So whether it is measured halfway between the posterior globe and the orbital apex, and how the vertical index is calculated. The measurements are given on the screen, and index, which one is the vertical index and which one is the transverse index. The larger value of each in each orbit is considered as the Barrett's index. So whether the Barrett's index more than 50% has a high risk of dysthyroid optic neuropathy, or whether we should use the Barrett's index along in conjunction with an ophthalmologist clinical assessment, or whether it can be used as an individual entity to just predict the dysthyroid optic neuropathy. The question, there is a correction, which is the wrong statement about the Barrett's muscular index.
Next question, ma'am.
So this question is to identify this MRI sign in Graves' ophthalmopathy. Whether it is a lacrimal gland herniation bilateral, whether it is a thickened lateral rectus bilateral, or a thickened inferior oblique, or whether this is a thickened fat pad.
Next question, ma'am.
So, which is the treatment modality to be avoided in dysthyroid optic neuropathy? This has already been discussed by Dr. Ankush. Whether it is teprotumab, whether it is tocilizumab, whether it is rituximab, or it is orbital radiotherapy.
Next question.
So which among is the false statement regarding medullary thyroid carcinoma? Postoperative serum calcitonin when goes less than 10 picogram per ml, it suggests less chance of recurrence. In medullary thyroid carcinoma, the doubling time of CEA and calcitonin are reliable indicators of disease progression. PSMA PET scan can be used in identifying metastatic medullary thyroid carcinoma. Selpercatinib and prasalitinib is used in non-metastatic RET mutant medullary thyroid carcinoma. Which among is the false statement?
Next question.
So in differentiated thyroid carcinomas, when we go for the radioiodine uptake and ablation regime, so what are the regimes used to increase the iodide uptake by NIS transporter? That is, how do we keep the TSH more than 30 MIU per ml before giving the radioiodine uptake? So thyroid hormone withdrawal by withdrawal of levothyroxine 4 weeks prior, or thyroid hormone withdrawal by substituting the levothyroxine with leothyronine for the first 2 weeks, followed by discontinuation of T3 for the next 2 weeks, whether to give recombinant TSH 0.9 milligram IM 24 to 48 hours prior to the radioiodine scan and continue with the thyroxine, or is it all of the above? Which one is the true statement? Which is the regime used?
Next question, ma'am.
So, which is a wrong statement about thyrotoxicose in pregnancy? A serum TSH, which even undetectable, may be present in women by 11 weeks of gestation. And TRAB TSH receptor antibody is to be done at 24 to 28 weeks of gestation in patients with a past or present history of Graves' disease. Biochemical evidence of hyperthyroidism in pregnancy is evident when the serum HCG levels is between 1 lakh to 5 lakhs international unit per liter. TSH cutoff in pregnancy should be less than 2.5 MIU per liter. Which one is the wrong statement?
Done, ma'am.
Thank you.
Dr. Antrisa, you can discuss the answers and then we can display the results of the DM quiz.
Yes. So, shall I start discussion, sir?
Yes.
So, from the first question, this is a question from our Thyroid Research and Practice Journal. And from this original article by Khara et al., it clearly states that the levothyroxine absorption is reduced in presence of food from 79% under fasted condition to 64% under fed conditions for a 100 microgram dose. So in the next question, the treatment answer is beta blockers because we only need to stop having the peripheral signs of thyrotoxicosis. For that, if the patient is non-asthmatic, we can use beta blockers. The carbimazole does not have a role in this because in thyroiditis, the excess hormone is already been released from the gland and it is not newly synthesized. IVIG have just kept it there, and because the radioiodine uptake is negative, there is no role for radioiodine ablation also. So, Cogan-Littwich sign is not related to thyroid eye disease. Ballet sign is restriction of one or more extraocular muscle movements. Cogan-Littwich is classically described in myasthenia gravis. It is described as a brief twitch of eyelids on upgaze, followed by a droop of the eyelids. Dalrymple sign everyone is familiar with, and also Gendrasik sign is paralysis of all extraocular muscles. Hope nobody had not confused it with our Gendrasik maneuver in neurology. So when we decide to give the patient combination treatment with levothyroxine and leothyronine, and if we find that the TSH is suppressed, we should understand that we should reduce the levothyroxine dose further. And this is again from our Thyroid Research and Practice Journal. And when we start the leothyronine treatment, when indicated, levothyroxine dose should be reduced by 25%. And leothyronine can be started at 5 mg twice daily and maybe go up to 7.5 milligram twice daily. And serum TSH should not be suppressed. So this question is actually, which is the wrong statement about Barrett's muscular index. So this is how it is measured. And Barrett's index, more than 50%, more than 60%, more than 25%, many of the articles describe a different cutoff for the Barrett's index. So this should not be taken in isolation so as to identify the risk of dysthyroid optic neuropathy. It should always be interpreted in conjunction with an ophthalmologist clinical assessment. So that is the statement. The wrong statement would be the cutoff value regarding the risk of dysthyroid optic neuropathy, because it varies in various studies. And in this MRI, we can see this is a bilateral lacrimal gland and it is getting herniated. So this is also described in the Graves' ophthalmopathy. So these are bilateral lacrimal gland herniation. So treatment modality to be avoided in dysthyroid optic neuropathy is rituximab. Dr. Ankush has already mentioned that it will cause flu-like symptoms by release of cytokines and also might even worsen the dysthyroid optic neuropathy. Orbital radiotherapy can even be considered. So which is a false statement regarding medullary thyroid carcinoma? PSMA PET is also currently described as to identify metastatic MTC because the ligand tagging, PSMA can also tag the medullary thyroid carcinoma. However, selpercatinib and prasitinib is tyrosine kinase inhibitors, which is usually given in metastatic medullary thyroid carcinoma. F18 DOPA, gallium dotatate, and also PSMA PET can also be used as radioligands. And we all know that all these regimes can be used in differentiated thyroid cancers before proceeding with the radioiodine uptake. This is again from the journal article. So which is the wrong statement about thyrotoxicosis in pregnancy? So the TSH cutoff in pregnancy should not be less than 2.5 MIU per liter. So again, we have our consensus statement from the Indian Thyroid Society. We should be using population-specific cutoffs. So that is like every population should have these cutoffs by screening adequate number of individuals. So if that is not available, the TSH cutoff can be taken as 0.5 MIU with the general population cutoff, less than 0.5 MIU. That is given in detail in our thyroid disorders in pregnancy guidelines.
Thank you, Dr.
That's
Antrika.
also.
Shyam, can we have the results of the DM quiz?
Yes, sir, we have the results. I'll just display it.
Okay. Okay, so the winners of the DM quiz for today, first prize goes to Dr. Priyanka, second is Dr. Suyash Gupta, and third is Dr. Siddharth Panigrahi. I congratulate all the winners of the DM quiz on behalf of the Indian Thyroid Society, and you'll get a certificate of merit from the Indian Thyroid Society by email. Congratulations to all the winners. So we can go on to discuss the practitioner's quiz answers, and then we'll declare the practitioner's quiz, which was already conducted. Dr. Antrisa, practitioner's quiz.
Okay.
So discussing the answers of practitioner's quiz. In newborn screening of thyroid disease, a cutoff TSH value more than 20 is considered, less than 20 on day 3 to 5 of birth via direct sample or via cord blood is considered as normal. This is from the ISPE guidelines 2018. Iron deficiency may contribute to hypothyroidism by reduction of the function of thyroid peroxidase because it acts as a cofactor to thyroid peroxidase enzyme. So non-thyroidal illness or sick euthyroid syndrome is characterized by, it can be precipitated by stress or trauma or malnutrition. It does not require thyroxine therapy as it usually gets resolved by itself. There is reduced T3 and however does not have reverse T3. There is increased formation of reverse T3. That is why the T3 is getting reduced. And when there is a patient with negative technetium-99 uptake scan along with their low thyroglobulin, suppressed TSH and elevated T, we should always, because indicates that the source of the thyroxine is definitely from an outside source. So what are the risk factors of thyroid eye disease? Smoking is a risk factor. And in severe cases of thyroid eye disease, radioactive iodine therapy may exacerbate the eye disease. And high TSH receptor antibody levels also will exacerbate the thyroid eye disease. However, thyroidectomy is a safer option when other modalities cannot be done. Thyroid eye disease treatment. So the self-solving curve, so there's a peak followed by a trough, whether the eye disease remain inactive after a while. So which is the preferred antithyroid drug in first trimester of pregnancy? It is propyl thiouracil because there is a high risk of congenital malformations with carbimazole, and propyl thiouracil, even though it has a risk of hepatic necrosis, we prefer propyl thiouracil in the first trimester and move on to carbimazole in the second trimester. With preferred imaging modality in a patient with thyroid nodule with suppressed TSH. It is thyroid scintigraphy, whether to assess the functionality of the nodule. This is again a question taken from the consensus statement by Indian Thyroid Society. When a patient's calcium is assessed, we have to do the albumin simultaneously so as to get the corrected calcium values. The calculators are available online, or either it is available calcium plus 4 calcium into 0.8. So that is how we calculate when the patient is severely sick or whether with low albumin levels, the calcium can show spuriously low values. And so as to do not give over treatment, we have to always go for the corrected calcium levels. The recommended starting dose of thyroxine followed by total thyroidectomy and remnant ablation in a 30-year-old lady with 30-year-old patient with papillary thyroid carcinoma is 2 microgram per kilogram per day, because we need to start the patient on suppressive doses of thyroxine. That's all, sir.
Thank you, Dr. Antrisa.
Thank
you
you,
for
sir.
both the quiz, the DM quiz and discussing the answers, and the practitioners quiz and discussing the answers. It was a good learning experience for everyone. Tech team, can we have the results of the practitioners quiz?
Yes, sir, sure.
So the winners of the practitioners quiz, this was held before itself online. So the winner is Dr. Mohammed Gauss. First prize goes to Dr. Mohammed Gauss. Second is to Dr. Prabhuram. And third is Dr. Vishal K. Vaidya. I congratulate all the winners of the practitioners quiz on behalf of the Indian Thyroid Society. You will receive a certificate of merit by email from the Indian Thyroid Society. So today we had a good clinic session. So we had a good case presentation on orbitopathy with dysthyroid optic neuropathy by Dr. Ankush Rukneja. And we've had another session on Graves' disease, expert talk on Graves' disease with papillary microcarcinoma and malignant ophthalmopathy from pathogenesis to practice by Dr. Pooja Ramakant. So we had a different spectrum of thyroid eye disease, which was seen today. And we had an excellent DM quiz and practitioners quiz presented by Dr. Antrisa. And the next ITS clinics will be having on 8th of October, which is the second Wednesday. So kindly block your dates for 8th of October. And tech team, can you display the next date? So next session of ITS Clinics webinar is on 8th of October, second Wednesday. Kindly block your date, same time, 8 o'clock. So we'll look forward to an interesting session of another thyroid clinics. So I think already they have shown about the practice, the Thyroid Research and Practice Journal. Kindly consider submitting your research with the world to Thyroid Research and Practice Journal. You can scan the QR form or you can go online and try to submit your research. If you are interested in being a reviewer, you can consider being a reviewer for Thyroid Research and Practice Journal. So can we conclude with yes.
Thank you very much. Yeah.
Thank you. All the sessions are available on the ITS website. I thank all the faculty and all the delegates for joining this session, and the speakers and the quiz master, Dr. Antrisa Jose. Thank the tech team for their help. Thank you. We can conclude the session.